My name's Mutambo Poster. I'll actually be presenting on because was actually presented and of the spinal cord was given. Yeah, and I'll actually continue from where my colleague Gus will be actually on the internal will be the layout of our presentation. First, let's talk about the spine. I'll also talk about the ascending tracts and the descending tracts, then the clinical, which is just simply the anatomy that, yeah. So this is just an image that is actually showing the cross section of the internal spinal cord, of which the internal spinal cord is actually divided into the white matter and gray matter, of which the only thing that differentiates the two, the gray matter is actually neuronal cell and myelinated. So the unmyelinated cell bodies are the ones that make up the gray matter, hence giving it its gray color. All this, the reason why the myelinated, the gray matter is further divided into the posterior one, and it is also further divided into the gray one, then into the lateral one, and anteriorly the anterior one, of which the posterior one is actually, its main function is to receive sensory information. Yeah, it's to receive sensory information, whereas the posterior aspect tends to get involved in the motor function of the spinal cord. Yeah. Then the white matter is also further divided into the posterior funiculi. The posterior funiculi, which is also involved in the sensory function. Yeah, then it is further divided into the lateral funiculi, or funicula, sorry, then into the white commissure. So a commissure, basically, it only tends to provide connections in the spinal cord from the left to right. So it's sort of an associated, it's made up of associated neurons, yeah, which tend to provide connection from the right to the left nucleus, which is involved in the move of the spinal cord. So it tends to receive motor information from the brain, then it is further sent to the peripheral organs. Yeah. So a funiculus myelinated, or a funiculus can also be called a column. Yeah. Yeah. So the spinal cord has also what are called spinal nerves, of which these spinal nerves be divided into root and the, of which the anterior root tends to send the motor response. The posterior tends to receive sensory information. And I think from this diagrammatic diagram, you are able to see the different parts of the gray matter and the type, the kind of functions that they're involved into. Seeing that the anterior aspect, which is actually colored blue, is involved in what? Sensory function of the somatic organs. Then the lateral part being involved in the sensory functions of the visceral organs. Then further, the anterior aspect of the gray matter being involved in the autonomic and the somatic motor responses. Yeah. So the spinal cord is further organized into what are called nuclei and laminae. Yeah. So like I said, in a column or a nuclei is just a group that are unmyelinated and what are called layers. Yeah. So these so-called laminae are just organizations, or actually described by a scientist when he examined the histological sections of a neonatal cat. Yeah. So these numbering systems, if you from the diagram, as you see, the Roman numerals have actually been used to number these laminae or layers. Yeah, and you don't have to like memorize all of them, because mostly these layers or laminae are actually significant when it comes to neuroscientific experiments. That's one of the significance of these laminae. And the other thing that you have to observe is you find that these laminae and these nuclei or columns, they're actually associated. And the association is actually showed by the colors. You can see that there is an association between these nuclei and these columns. You find that each lamina is associated with a particular nuclei, which entails that association means they might be carrying out almost the same function. So I want us to take a deeper dive in what are called nuclei. So like I said, a nuclei is just a cluster of neuronal cell bodies, or a group of what? Neurons that make up what? That's what make up what? A nuclei. So now these nuclei are divided. They're actually divided into three, of which the first is the anterior group of neurons. So some other, depending on the literature that you're using, some may call them the anterior group of neurons, some may call them the anterior nuclei, some may call them like my PowerPoint here, saying the nerve cell groups in the anterior gray column, because the column and the nuclei are one and the same thing. Then the second type of these nuclei, we have got the nerve group in the posterior gray column. Yeah, sorry for that. Yeah, in the posterior gray column, and we also got another group or another nuclei in the what? In the lateral gray column. So I think you can see from the diagram that we have actually three types of nuclei. So the first nuclei is the anterior gray column. Yeah, the group of neurons are found in the anterior gray column. Then there's the second group are found in the posterior gray column. Then thirdly, we have those that are found in the lateral gray column. Yeah. So I want us to discuss in details. I hope the PowerPoint is clear. Just give me feedback if it's clear. Is it clear?
It's clear, though it's a bit blurred.
Yeah, I'm also wondering why it's blurred. Yeah, because I don't know if it's a network or I don't know why it's blurred. Yeah, I don't know why it's blurred. Yeah, I'm sorry. I'm actually sorry for that. Don't know if it's a network. I don't know. Yeah, I'm actually sorry for that. Yeah.
Not the network, but then you can go on though.
All right, thank you. Yeah. So we'll talk about the anterior group of neurons. Yeah, or the anterior nuclei. So as we said, you find that the anterior nuclei is found in the what? Anterior gray column. Yeah. Anterior gray column, the anterior aspect of the what? Of the gray matter. So now, this anterior group of neurons, or the anterior nuclei, is actually, it has what they call a somatotropic arrangement. As you can see, starting from medially, going laterally, it has the medial, it has the medial anterior group of neurons. Then it has got the central ones, which is colored green. Then it has also got the lateral group of what? Neurons. Yeah. So now, the middle group of neurons are further divided. Yeah, they are further divided into the ventromedial nuclei and the dorsomedial nuclei. Yeah. Now, these two nuclei in the medial nuclei, they are actually involved in what? In the motor function of the axial skeletal muscles, which are the muscles of the trunk and also the muscles of what? The muscles of the neck. Then the central group of neurons. Yeah, the central group of neurons. This central group of neurons, these are further divided into the what's this? They are further divided into the phrenic nerve nuclei. Then there are also the phrenic nerve nuclei, the uns nuclei, and the spinal accessory nucleus. Yeah. So now we find that the central group of neurons, they are actually located in the cervical and the lumbar sacral region, of which we know that the phrenic nuclei, which is actually located between C3 and C5, tends to, its function is it actually supplies the diaphragm. Yeah, it actually supplies the diaphragm, meaning it plays a role in what? Respiration. In order for your diaphragm to flatten and make these neurons play a vital role in order for someone to breathe. Of which, if maybe someone sustained an injury between C3 and C5, one might lose their ability. One might lose their ability to breathe. That's the more reason why when someone sustains a brain injury, the first thing that we have to do is we don't start with the ABCs, but we start with the C, which means first we have to secure the cervical collar, so as to prevent the loss of life, as if someone might lose the ability to breathe, and that might lead to the death of the patient. Yeah. Then the lateral nuclei, which is actually located in the cervical and the lumbar sacral, lumbar sacral enlargements, is further divided into the retrodorsal lateral nuclei, then the dorsolateral nuclei, and the ventrolateral nucleus. And this is actually involved in the contraction of what? The limb, the limb muscles. Yeah. Yeah. Then we'll move and talk about the neurons of the posterior. We'll further look at them. The neuronal groups in the posterior gray-on, of which we know that the posterior gray-on itself is involved in sensory function. So there are about 3 important locations that we have to actually discuss when it comes to the posterior group of neurons, of which the first one is the substantia gelatinosa of Rolando. So this the substantia gelatinosa of Rolando actually occupies all levels of the spinal cord, and it actually contains the Golgi or the Golgi type 2 neurons, and is actually involved in carrying or it's actually involved in receiving afferents of pain, temperature, and touch and touch sensations. Yeah, and touch sensations through the posterior, the posterior spinal root. Yeah. And the one thing that you also have to also understand about this about the substantia gelatinosa of Rolando is that it is actually, in as much as it tends to pick up pain sensations, it actually takes up the specific type of sensation, pain sensation it actually receives is slow pain. Yeah, not fast pain, but actually slow pain. It's what is actually involved. Slow pain can actually described by a dull pain that one can be described as, it can also be described as dull pain, a pain such as pain maybe from the viscera, such kind of pain. Pain maybe from, if maybe one is having arthritis, yeah, such kind of pain. This is a pain one can actually receive. The substantial gelatinosa of Rolando actually receives. Yeah, and it's actually the substantial gelatinosa of Rolando that actually even leads to the formation of the anterior and lateral spinothalamic tracts. Yeah, it's actually involved in that. And the other thing that it also does, it is also actually involved in pain modulation. In order to modulate your pain, it is actually involved in pain modulation. Then as it ascends up the spinal cord, it further becomes a specific nucleus of the medulla, which is the spinal trigeminal nucleus. It's what it becomes. So as it ascends up the spinal cord, it further becomes the spinal trigeminal nucleus in the medulla. Then we'll talk about the nucleus proprius, which is actually anterior to the substantia gelatinosa of Rolando, which is associated with lamina 6 to 7, and it's located with it is located between it is located between C8 to L4, and this one is actually associated with proprioception. It is actually associated with proprioception. Then the nucleus proprius, this is actually it is actually made up of large nerve cells which are anterior to the substantia gelatinosa of Rolando, and the fibers and also the fibers from the white column. It is actually involved in position sense and movement, and also it's also involved in receiving sensations of 2-point discrimination or 2-point discrimination and vibration. So 2-point discrimination is just basically a patient being able to differentiate different points. This is mostly appreciated when you're doing a neuro exam. Yeah, where you're told where you tell the patient to actually differentiate 2 points that maybe using an object, you change its position and ask the patient to tell you where its position is. Yeah, and this is actually the area of the gray matter who are the vitamin B12, their 2-point discrimination abilities is actually lost in vitamin B12 deficiency. These patients tend to suffer from the subacute combined degeneration of the cord. Yeah. Then the last part of I want us to talk about is nucleus. Yeah, so and is lateral to the nucleus dorsalis. Yeah, that is at T1 to T3. Yeah. Then we further intermediate. So intermediate gray column, lateral gray column is actually made up of the medial nucleus, which actually gives rise to the sacro parasympathetic gray column between S2 and S4. So meaning if maybe one has injury in this part of the spinal cord, that is between S2 and S4, meaning the parts of the body that are actually innervated by these nerves below the injury are affected. an example, because we know C1 to C4 also tends to innervate the what? The rectal muscles, and also your muscles of what? Of your penis, so that you're able to, so that one is able to have an erection. So meaning if one has meaning as an injury, at this level, so meaning this person might lose their ability to even control their rectal sphincters, meaning they will have fecal incontinence and urine what? Incontinence. Yeah. And then the intermediolateral nucleus actually tends to give rise to the preganglionic fibers of the sympathetic nervous system. And this actually tends to extend in the thoracolumbar region, which is between T1 to L2, of which we know that in this segment, this is where the sympathetic aspect of the sympathetic nerve fibers originate from. So meaning the sympathetic function of someone might be affected if maybe one had a tumor or had an injury, or maybe had an herniated disc in this location. One might lose their sympathetic function. If maybe one maybe sustain maybe an injury in this section, these are people that might even get what? Neurogenic shock. So this is just we'll just talk about, I'll go more in details in talking about the laminae. Yeah. So the spinal cord has what actually a cytoarchitectural lamination organization, or it's actually organized into laminae, of which this was actually just described by a scientist called Rex. He actually divided divided the sections of an neonatal cat's brain into 10 layers, and of which this has also been used in humans when they're carrying out experiments, maybe for example when it comes to degenerative disorders. And yes, slices of the spinal cord are actually taken down and used to locate where the degenerations are coming from and why a patient is presenting in a certain way. Yeah, that's one thing that you have to remember about this. So you find that, like I said, they're actually divided into 10, of which laminae 1 to 4, they are involved in exteroceptive sensations. So what I mean by exteroceptive sensations, these are just sensations that are due to external stimuli. So external stimuli, which might be light, might be a change in temperature, it might be due to position, yeah, vibration, sense, yeah. So these are the sensations that these laminae from 1 to 4 actually receives. Then from 5 to 6, they tend to receive proprioceptive sensations, which they relay between the midbrain and the cerebellum. Yeah, and then 6 tends to give rise to the spinocerebellar pathways, yeah, or the spinocerebellar tracts. Then lamina 7 is actually involved in the visceral motor function. So meaning the visceral organs might lose their motor functions if maybe there was a lesion or a pathology in this region. Yeah. Then lamina 8 to 9 tends to give out the final motor output. Yeah, then lamina 10, this is where spinal decussations, or this is where spinal fibers tend to cross, yeah, in the spinal cord. Yeah. So yeah, this is where spinal fibers tend to cross. So we'll talk about the white matter. So white matter is also just a mixture of nerve fibers, neuroglia, and also blood vessels. So it tends to surround the gray matter, which tends to give the gray matter a butterfly or an egg-shaped appearance. Yeah. Then it is white because it is made up of myelinated nerve fibers. And we know that myelinated nerve fibers tend to transfer action potentials at a very fast rate. So the type of fibers that are actually found in the white matter, we've got sensory fibers, which tend to send information from the spinal cord to the brain, yeah, or to the cerebral cortex, yeah. Then we've got the motor fibers, which tend to send information from the brain to the spinal cord, then further into different body organs. Then we have got association fibers. So these association fibers are actually involved in the transfer of information within the white matter. This is maybe from the right to the left, or from one section of the white matter to another. Yeah. So the white matter is further divided into the it is actually further divided into the anterior column or a funiculus. So like I said, a funiculus is just actually a bundle of myelinated nerve fibers. Yeah, that's actually a funiculus or a column. Then it's further divided into the lateral white column, the posterior white column, and the anterior white commission. This is where actually decussations actually tend to happen. The white matter. I'm sorry, I don't know what has happened to my PowerPoints. I don't know why they're blurry. I don't know. I was wondering why. I'm hoping maybe it's because of the screen that I'm using. Somehow maybe small. I really apologize on that. I'm hoping the rest of the images will be good quality and you'll be able to appreciate these things. Yeah. So like I said, the white matter is made up of a mixture of what? Fibers. And these fibers actually bundle together to form what? A tract. A tract which actually is just a collection of what? Axons. And these have got actually the same origin, they have also got the same course and also the same termination. Yeah. The same termination. Yeah. So tracts are actually divided into ascending and descending tracts, of which the ascending tracts tend to send sensory information from the spinal cord, which is received from the receptors. Then the spinal cord then sends to the brain, and the information, when interpreted in the brain, it is further sent down through the what? Descending tracts. So the ascending tracts tend to send information from the spinal cord to the brain. Then the brain sends the what it has interpreted, or the motor response via the descending tracts. Yeah. So I'm really sorry about the images. Too blurry. So sorry, I don't know. Just my screen, I don't know. Yeah. I'm just hoping you're able to see on your ends. Yeah.
Yes, we can see. Continue, please.
All right. Yeah. So the ascending tract, like I said, it tends to send information from the spinal cord to the to the brain. It tends to send sensory information from the spinal cord to the brain. So it is actually further divided, starting from the posterior aspect to the anterior aspect. It is divided into the posterior funiculus, the posterior funiculus medial-lemniscal pathway, or the dorsal column medial-lemniscal pathway. Yeah, which is further divided into the fasciculus gracilis and the fasciculus cuneatus. Yeah, which is actually an advanced center. Yeah, it's actually an advanced center. Then it is going ventrally. It is further divided into the spinal cerebellar pathways. Yeah, the spinal cerebellar pathway. Yeah, for which we have the posterior cerebellar tract and the anterior cerebellar tract. Then we also anteriorly we have the anterior lateral pathways, which is the lateral spinal thalamic tract and the anterior spinal thalamic tract, which the anterior spinothalamic tract is actually involved in crude touch or light touch. Yeah, and also involved in receiving information from the pressure receptors. Yeah, and while the lateral spinothalamic tract is actually involved in pain and thermal sensations, while the advanced center, which is the dorsal column medial-lemniscal pathway, is actually involved in receiving sensory information for fine touch, 2-point discrimination, vibration sense, and also conscious proprioception. Yeah. While the anterior spinocerebellar tract is actually involved in the unconscious proprioception and also gross movements. The posterior cerebellar tract is actually involved in unconscious proprioception and fine movement. But for the sake of this presentation, we will actually just focus on the two ascending pathways, which is the posterior funiculus medulla-lemniscus pathway, or the dorsal column medulla-lemniscus pathway, and the anterolateral pathway, or the anterolateral spinothalamic pathway. For this one, I actually wish the board, and I was actually for people to appreciate what I'll be talking about, so that I can at least be pointing so that people are following. Yeah. So the dorsal column, like I said, is an advanced system. Yeah, we can even see its function. It is actually involved in fine motor, and receiving sensations for fine motor function. Yeah, sensations for fine motor function, vibration sense, and also proprioception. Now, the dorsal column itself, we see that it is actually in the posterior. It's actually located in the dorsal, like the name says, the dorsal column, meaning it is in the posterior aspect of the white matter. So it tends to receive sensations from receptors, from different receptors, such as the Meissner's corpuscle, the Pacinial corpuscles, and the muscle spindles and the tendon organs. This is where it receives its sensory information from, or action potentials from. Yeah. So now what happens is that when these receptors send action potentials, then to send action potentials to the via the posterior root ganglion. They tend to send these action potentials via the posterior root ganglion. which now further relays, it tends to relay information now. It tends to course down the dorsal column. Then it does not actually decassate at the spinal level. No, it actually moves superiorly. Then it actually tends to synapse. You can say synapse, or which is the first order of neuron, tends to synapse or terminate in the medulla, in the medulla or oblongata, where the spinal nerves from we know that actually in the dorsal column, they actually it has got a somatotropic arrangement of two areas that we have to be aware of, which is the fasciculus gracilis and the fasciculus cuneatus, of which we know that fasciculus gracilis is more medial, which is green colored, and the fasciculus cuneatus is lateral. So meaning sensory information from the fasciculus cuneatus is actually relayed at the nucleus cuneatus in the medulla oblongata. Then sensory information from the nucleus, the fasciculus gracilis is actually relayed at the nucleus gracilis in the medulla oblongata, which further now tends to form the second order of neuron, which is called the acute fiber. So the acute fiber tends to decassate before it enters through the medial lemnisca, before it enters into the medial lemniscus pathway. So of which we know that if we are going to have a lesion below the medulla oblongata in this region, meaning someone will present with it, they will lose their ability, their sense of proprioception, or they will present with symptoms of maybe failure to appreciate fine touch, or they will lose their position sense in the ipsilateral, in the ipsilateral format, meaning the symptoms. So if an injury happens below the medulla oblongata, so meaning if the injury happens below the medulla oblongata, someone will present with sensory deficits on the same side of the lesion. But if it happens after this decassation or the crossing over on the opposite side, meaning the patient will tend to present with sensory deficits or sensory dysfunction on the opposite side of the lesion. So for example, if the lesion is on the right side above after superiorly to the decassation, so meaning the sensory function will be lost below the lesion on the opposite side of the lesion. That's the point that I wanted to actually put across. So then, as it courses above the mid, as it forms the medial lemniscus tends to terminate in the thalamus at the ventral-posterior nucleus of the thalamus, then further gives off the third order of neurons to the post-central gyrus or the primary sensory cortex. So their interpretations are done, and the brain interprets the information, and a response is sent via the descending tract. So basically, that's what I wanted us to understand. And one thing that you also is that involvement and the posterior nerve roots in for example, someone who has got syphilis. So these patients might have what they call debs dorsalis. Basalis, which is just a syphilitic degenerative disease that tends to lead to loss of sense of position in these patients. Yeah, of which we know that they're losing the sense of position because we know that it is actually in the dorsal column where it's because it's actually the dorsal column that actually receives proprioceptive what? Sensations. Yeah. So meaning if degeneration of the white of the posterior white column happens, so meaning they might lose their proprioceptive ability, meaning they will lose their position sense. Yeah. So if maybe these patients might not be able to tell the position or movements of the lower limbs unless if maybe they are able to see them. So it's unless maybe you tell them, okay, move that way. But if they close their eyes, they wouldn't move because they wouldn't know where their limb is. They wouldn't be aware. Yeah, that's one thing. And these patients further tend to as you're examining them, as you're examining such patients, you find that they might, if you ask them to stand up with their feet together and their eyes closed, they might stagger and maybe even fall down because they cannot maintain a correct position due to lack of what? Proprioceptive information. And this is what we call the Rhombex sign. Usually for the students, this is something that you might even be asked in an OSCE or a short case. Then we'll talk about the anterolateral spinothalamic tracts, and we'll first talk about the lateral spinothalamic tract. So we see that the lateral spinothalamic tract is actually involved in, is actually tends to carry pain and temperature sensations. Yeah, pain and temperature sensations, whereas the spinothalamic, the anterior spinothalamic tract tends to carry sensations of crude touch and pressure. Yeah. Yeah, and these tend to receive nerve impulses of these sensations from the free nerve endings. Yeah, which are found in the skin and the different parts of the body. Yeah, different different parts of the body. Mm-hmm. So these tend to give to the first order of neurons. As you can see, the first order of neurons is actually in green, and as it courses down the posterior aspect, which is the posterior white column, it gives off the what? The second order of neurons, which actually tends to actually cross over on the opposite side. So these tend to cross over on the opposite side. So meaning they decassette. Yeah. So meaning if someone had a lesion here, yeah. If someone had the lesion here in the anterior gray commissure here, if someone had the lesion here where they're crossing, yeah. So at the lesion in this region, meaning someone would lose their pain sensory. They will have sensory dysfunction to pain bilaterally because this lesion is actually located on the central portion. Yeah, that's one aspect I want you to actually appreciate about these tracts. Yeah, in the case that someone sustained an injury in this region, or maybe in this region, or they had maybe a tumor in this region, the patient might have bilateral sense of loss of pain sensations bilaterally. Yeah. Yeah. So as they ascend, they tend to form the second order of neurons tends to form the lemniscus. The spinal, they go through the spinal, the meniscus, in the medulla, then they further course in the thalamus, specifically the ventral posterior lateral nucleus of the thalamus. Then further they give out the third order of neurons, which go to the postcentral gyrus, which is the primary sensory cortex area. Yeah, and information is there. So if we are having a blockage here, meaning if we are having a lesion here on the anterior white commissure, meaning here there will be blockage. So meaning information won't be passing and going up to the brain. So meaning someone won't be able to lose their pain sensation abilities. Yeah, they will lose that. Yeah, and the other thing that that I want you that I want us to also appreciate about this arrangement is that you find that pain fibers in the lateral spinothalamic tract, specifically in the cervical region, you find that the pain fibers have become very superficial in the cervical region, and these pain fibers that become very superficial in the cervical region, they are actually lateral to the white column, or to the white column. So, seeing that they become so superficial, there is actually in the cervical region, there is actually a procedure that we call a cordotomy, which is actually performed in this region. Yeah, at this level. So in the cervical region, you can perform what procedure called a cordotomy to relieve pain on the opposite side of the body, because we know the lateral spinothalamic tract tends to cross at the level of the spinal cord. So meaning if you perform what we call a cordotomy, or you try to resect these spinal nerves in this region, one will lose. You might be able to relieve pain in the opposite side of the body. This is actually a procedure that is done in people that have excruciating pain, or pain that does not go away and that is so severe. So such a procedure can be performed, which is called a cordotomy, where in the cervical region, a certain portion of the lateral spinothalamic tract fibers are resected to relieve pain on the opposite side of the body. Yeah. Then we'll talk about the anterior spinothalamic tract. Actually, the way these tracts actually move up into the spinal cord is just actually the same. It's actually just actually the same as the lateral spinothalamic tract. The only difference is that the anterior spinothalamic tract tends to, when it crosses over, it crosses to the anterior aspect of the anterior white column, whereas the lateral spinothalamic tract crosses over to the decussates into the lateral spinothalamic tract. The one thing that I want us to appreciate about this one is that damage to the spinothalamic tract might lead to loss of light touch and pressure on the opposite side of the body below the lesion, if we had the lesion in this case. Yeah, so if we had the lesion in the anterior aspect, in the anterior right column, yeah, in the anterior white column, for example, So below that, on the opposite side of the body, we might lose the sense of light touch and pressure. Yeah, so this is just another tract that we can talk about, which is actually the tract of Lessar, which is actually gives off the first order of neurons that enter. It gives us the first order of neurons that enter the posterior horn, and it tends to divide into the ascending and the descending branches that travel for about 1 to 2 segments, and these tend to terminate with the second order of neurons in the substantia gelatinosa of Rolando. Yeah. So now we are going to talk about the ascending tracts. So the ascending tracts, basically, ascending tracts now tends to so the moment sensory information has been now sent to the brain. Now interpretation has taken place in the different aspects of the brain, cerebral cortex, and a certain the cerebral cortex information has now to be sent now down. The motor response has to be given down, and now it has to be sent down till it reaches that specific organ that needs that specific response. So the motor response will be via the action potentials will be sent via the descending tracts down to a response is what is given. Yeah, so that's the importance of this descending tracts. It tends to send, they're in charge for what? Motor response, and tend to deliver the motor instructions from the brain to the spinal cord. And these are further divided into the pyramidal, or what we call the cortical tracts. So the reason why they're also called the reason why they're called pyramidal tracts is because as they cross over in the medulla, in the medulla oblongata, as they cross over, they tend to pass through what are called medullary pyramids. So as they pass through those medullary pyramids, they form some sort of a pyramid. That's why they're given such a name as pyramid. That's why they're also called pyramidal tracts. And they're called corticospinal tracts because they're sending information from the cortex, the cerebral cortex, to the spinal cord, hence the name corticospinal tracts. These have also got an indirect pathways. They've also got indirect pathways. And these motor pathways that these send, that course from these descending tracts, they are further divided into the upper motor neuron, the upper motor neurons, which move from the cerebral cortex to the spinal cord. Then the lower motor neurons move from the spinal cord to the specific organs or muscles that they have to innervate. So the corticospinal tracts, or the descending tracts, the corticospinal tracts or the ascending tracts, they are themselves, like I said, they tend to send motor information from the spinal, from the cortex down to the spinal cord, and this is how these descending tracts course. So as they move down, one of the most significant things that you have to know is that as they course down, as they come down, as they run down, they tend to decassate at the medulla oblongata. That's why they tend to decassate. So meaning if one had a lesion, so if one had a lesion, for example, in a case of a stroke or anything happens, meaning these patients are the patients that might even suffer from maybe hemiplegia, which is paralysis. paralysis. So if maybe an infarction occurs in the cortex of the brain, so meaning these patients might have might present with hemiplegia. So for example, if it's the right side of the brain that has been affected, so meaning these patients, because these fibers, as they are coursing down, they tend to decassette, they tend to cross over. They tend to cross over and divide, and they tend to cross over at the medullary pyramids here. So meaning what will happen is that, so seeing that they're crossing over, so if a patient has a lesion, for example, maybe a tumor or maybe a stroke, this patient might maybe present maybe with hemiplegia. If it's on the right side, they might present with hemiplegia or hemiparesis on the, if the lesion is on the right side, they might present with hemiplegia or hemiparesis on the left side of the body, or the opposite side of the body. Yeah, that's one thing that you can remember about these tracts. Yeah. I hope everyone is following. The presentation is quite long. Yeah, I hope everyone, I haven't lost anyone.
Yes, we're following, please, we're following.
Oh, all right. Yeah. So the one thing that I want us to get now a deeper dive on the clinical correlates. So we'll try to differentiate what upper motor neuron lesions are and what lower motor neuron lesions seems to present. Yeah. The only problem is that slides, I don't know why they are blurred. Yeah. I wish I would use a different type of document, maybe Word, or maybe PDF, sorry. Yeah. So I don't know, is the slide clear or it's blurry?
Oh, the slide is blurry. The slide is blurry, but just try to explain each point, please.
Okay, then I will try to just explain. Yeah. So upper motor neuron lesions and lower motor neuron lesions. So upper motor neuron lesions are basically based on what I was just talking about, which is the descending tract. The descending tract, which is the corticospinal tract, is the one tract that one has to understand. Yeah, in order to understand what are the upper and the lower motor neuron lesions. Yeah. So like so the upper so in order to understand this, we need to know what upper motor which are upper motor neurons and the lower motor neurons. So of which the upper motor neurons, so these are these are tracts. The corticospinal tract is a upper motor neuron. What is a upper motor neuron? That's an example of a upper motor neuron. Then also the corticobulbar is a type of upper motor neuron. Then for the lower motor neurons, an example of a lower motor neuron is the anterior gray horn, and also the cranial nerve nuclei, which are located somewhere in the brainstem. An example is a trigeminal nucleus, the facial nerve nuclei. Yeah, the nucleus ambiguous. Those are the nucleus ambiguous, which has got a couple of cranial nerve nuclei, which are involved in speech, swallowing, and also articulation. Yeah, so these are the examples of upper motor neurons and lower motor neurons. Yeah. Then, so on the presentations, so they're actually about different aspects in which we can differentiate how motor neuron lesions present and how upper motor neurons present. So they can be differentiated in terms of tone, muscle weakness, the deep tendon reflexes, the plantar responses, and also fasciculations or wasting. So to start with, we would want to, since this is clinical anatomy, we would want to know what really causes these upper motor neuron lesions. So upper motor neuron lesions can be, upper motor neuron lesions can be actually be caused by different, due to different etiology. So one of the causes of upper motor neuron lesions, or one of the motor neuron lesions, a stroke can be an example of an upper motor neuron lesion. As we know, it is affecting what? The cortex of the brain. And another example are degenerative diseases such as multiple sclerosis, Friedreich's ataxia, and also subacute degeneration of the cord, which is due to the vitamin B12 deficiency. It can also be due to amyotrophic lateral sclerosis. Can also be one of the causes that might cause it can be also upper motor neuron lesions, as this is due to free radicals that tend to accumulate in the cell body. Yeah, it tends to destroy the cell bodies of the upper motor neuron, hence causing damage to the cell body, as it's due to accumulation of radicals, hence destroying the cell body. Then examples of lower motor neuron lesions can be due to things like poliomyelitis, which is viral, which is due to a viral cause, which tends to destroy the anterior greater horn. Then the other syndromes can be can be the caudal aquina syndrome. The diabetic neuropathy is also an example of a lower motor neuron lesion. Botulinism is actually also one where there is an inhibition of acetylcholine release at the nerve terminal. So now, what I want us to talk about is now how you can be able to differentiate between the upper motor neuron lesion and the lower motor neuron lesion. Now, the first thing that we are going to actually start with is we're going to start first with the tone. So we're going to start with the tone. Now, to understand the tone, that's why I wish this diagram was visible to have been easy to making illustrations. So to understand how this happens, so you find that in upper motor neuron lesions, you find that the tone is increased. There is actually hypertonia. And the other thing that happens is that there is the tone is actually increased, whereas in a lower motor neuron lesion, the tone is actually reduced. Now, we have to understand what really causes a decrease in the tone. What really causes an increase in tone in upper motor neuron lesion and a decrease in lower motor neuron lesions. So you find that where the decussation occurs, there is what we call there is actually a part of the medulla called the medulla reticulospinal nucleus. So the medullary reticulospinal nucleus, this tends to actually regulate the contraction of of muscles. It tends to reduce the ability of the muscle to contract. So, meaning if there is a lesion, which is, we know in a upper motor neuron lesion, if it is at a level of the spinal cord, it is actually in the medullary region. Yeah. So what will happen is there will be cut off of transmission of what? Motor responses or motor information from the spine. So they'll be cut off, the connection between the spinal cord and the brain will be what? Cut off. So meaning we will inhibit the control of contraction of the what? Of the muscles. So that cut off or that decrease in regulating the ability of the muscle to contract when it's cut off. So meaning the muscle will be contracting rapidly. I would call it without control. Yeah. So it will be hyper contracting. I don't know if there's such a term. Yeah. So meaning this is what will cause to hypotonia, it being what? Stiff. Yeah. Because the medullary reticulospinal nucleus has been what? Which is supposed to be controlling this aspect of the contraction of the muscle is not what? Is not working. The connection has been what? Cut off between the spinal cord and the what? And the brain. So meaning the control of contraction of the muscle won't be there. So hence the muscle contracting uncontrollably. So hence causing hypertonia. Yeah, that's one aspect. Then the other thing is because the sensitivity, yeah, okay, yeah. So you also find that the sensitivity of the muscle to contraction is what? Also increased. Is also increased, hence leading to what? Also increased, hence leading to increased in upper motor neuron lesions. Then due to that, this muscle is contracting so much, it will lead to what? The strength of the muscle is what? Is actually too much, hence causing spastic what? Paralysis. Yeah. So if someone has got upper motor neuron lesion, then the strength of the muscles, the muscles will be sort of not necessarily rigid, yeah, but they will be spastic. They will have spastic paralysis. Yeah. Yeah. Then if this patient is having a lower motor neuron lesion, you find that the medullary reticulospinal nucleus is working all right. It is working all right. But the problem is what? At the level of the spinal cord, and the cord has been cut off. Meaning sensory connection has been cut off completely. Yeah. So what will happen is the medullary reticulospinal nucleus is what is working. It is always inhibiting the ability of this muscle to what? To contract. And what will happen? So this decrease, yeah. So this decreased stimulation of the muscle will lead to what? Hypotonia, which leads to what? Hypotonia is just muscle flaccidness. And this decreased stimulation will lead to a decreased reflex, which is hyporeflexia, and also flaccid paralysis. That's what it will lead to. Yeah. Then the other thing that the other aspects I would also want us to understand is a part of what is the part of the muscle. I would call it muscle bulk. Yeah. Yeah. So you find that in upper motor neuron lesions, there's atrophy. Yeah, there's actually atrophy almost in both. But the type of atrophy that you get in both of these lesions, there's a difference. So you find that the type of atrophy that you would get in an upper motor neuron lesion is what we call disuse atrophy. So this disuse atrophy, it's because the upper motor, the cortex plays a role in voluntary ability of the muscles to what? To contract. So now when there's a upper motor neuron lesion, or if there's a lesion in the ascending tract itself. So what will happen is that the voluntary ability to contract the muscle be reduced. So that voluntary ability to control the muscles, what is going to lead to what? Atrophy or disuse atrophy. Then when it comes to the lower motor neuron lesion, you find that there's what we call denervation atrophy, because there is this muscle has been what? De-innervated. Yeah, it's not receiving its innervation. The innervation has been completely what? Cut off from the muscle, hence causing denervation atrophy. Yeah, as there is disuse of the muscle, hence causing denervation atrophy. This is the type of atrophy that one is going to get because the muscle is completely denervated. Yeah. Then the other aspect, you find that one might also get what we call fasciculations. Fasciculations which are just in lower motor neuron, which are only present when someone is having a lower motor neuron lesion. Yeah. Yeah, these are only present when someone is having a lower motor neuron lesion. That's when someone will have these fasciculations. And fasciculations are just basically involuntary pathological muscle contractions. Yeah. Yeah. And the reason why a patient might have these fasciculations is just due to a decrease in acetylcholine receptors activity. So we know if there's decrease in acetylCoA receptor activity, this tends to cause an upregulation in the number of receptors on the muscle. So hence leading to there's upregulation of these acetylCoA receptors on the what? On the muscle. So when there is hyperregulation, mean there will be more receptors on the number of acetylcholine receptors on the muscle will be what? Increased. So when they are increased, meaning the muscle will be what? Too sensitive, even just to mechanical movement. The muscle will be too sensitive, such that any movement might cause it to what? To contract uncontrollably, because it is too sensitive because of the increased acetylcholine receptors around the muscle itself, such as even just mechanical stimuli itself might cause it to contract. Yeah, so, and these can only be seen in lower motor neuron lesions. Yeah. Then other tests, the special tests that one can also just carry out is what we call the Babinski's the Babinski's test can be done. Yeah. So this lesion, the positive Babinski is seen actually in upper motor neuron lesions. Yeah. Yeah. It's actually seen in upper motor neuron lesions, and it's one test that is actually done during a neuro exam, and in children that are less than 1 year, it is actually positive. Yeah, it's actually positive in these patients. Yeah. Yeah, I hope everyone followed on that one. I know there's just so much information to take in, but the things that I would want everyone to take home is that and the Babinski sign is only present in upper motor neuron lesions. It is mostly present in upper motor neuron lesions. Then fasciculations, you mostly see them in lower motor neuron lesions. Then the type of atrophy that you get in upper motor neuron lesions is disuse atrophy, because the patient loses the ability to use the skeletal muscles. Then for lower motor neuron lesions, what the type of atrophy they'll get is denervation atrophy. Is a kind of atrophy patients will get. And the tone is in upper motor neuron lesions is increased. Reflexes, deep tone reflexes are increased, and the type of they will have spastic paralysis. Whereas in lower motor neuron lesions, the tone is actually reduced. the pterygium reflexes are reduced, they will also have flaccid paralysis. Yeah. So we talk about central cord spinal cord syndromes. So the first syndrome we're going to talk about is the central cord syndrome, which is mostly common of incomplete. It's one of the most common incomplete syndromes of the spinal cord. Yeah, it's mostly actually common in elderly patients, and it's mostly due to patients that are having spondylolysis or stenosis. It is rarely due to fractures. Yeah, and it tends to actually present with weak upper extremities, as we see it as a tendency of affecting the cervical region. Yeah, and in variable amounts, the bowel and the bladder dysfunction disproportionately the functions of the lower extremities. So what causes to anterior cord syndrome is just due to hyperflexion. It's mostly due to hyperflexion mechanisms, yeah, of the anterior segment of the spinal cord, and these patients tend to fail to control the motor functions below at least the region. Yeah, we'll talk about the Brown-Séquard cord syndrome, which is just the cord lesion. It is an incomplete. It is a type of lesion where it's only one side of the spinal cord that is actually affected. It's where the lesion does not affect the entire aspect of spinal cord, but just a certain part, just half, or just half of the spinal cord is affected. So in these patients, you find that for this presentation, this patient had actually had a lesion on the right side of the spinal cord, and they actually presented with dorsal column. They had actually a dorsal column lesion on the right side, of which they presented with epilateral loss of light touch, vibration, and position sense. Then it also affects the lateral corticospinal tract lesion. They also had the lateral corticospinal tract lesion, of which they presented with epilateral upper motor neuron signs. Yeah, of which the upper motor neuron signs, which we know there is hyperreflexia, hypertonia, spastic paralysis. These are the kinds of symptoms that the patient presented on the ipsilateral side, which is on the same side where which is on the right side where the lesion was. Yeah, for the lateral spinothalamic tract lesions, of which we know that these ones tend to cross in the spinal cord. Hence, the patient presented with contralateral loss of pain and temperature. Then there is the Conus Medullaris, which is actually due to injury to the lumbar and the lumbar and the sacral cord segments. So we see between S4 to 5, and which exit at A1. Yeah, which patient might have a fracture at this region. Yeah, and patients tend to present with a flexible bowel and bladder, might have flaccid anal sphincter and variable lower extremity loss. Pain might also have what we call coda equini, which tends to affect the lumbosacral nerve roots. This might happen with or without a fracture. And these patients tend to present with variable loss or reflex and radicular pain. We'll also talk about the amyotrophic lateral sclerosis, which is also known as Lou Gehrig's disease. So this one it's a demyelinating disorder. Yeah, it's actually due to accumulation of radicals that tends to destroy the neuronal cell bodies in the anterior horn, motor neurons, and fibers of pyramidal tracts. So we know the anterior horn is involved in what? The motor aspect of the motor aspect of the spinal cord. And it's in this same region, we have between C3 to C5. This is where the phrenic nerve is. And that's the reason why you find that these patients most of the time tend to die due to the respiratory failure. As we know, the phrenic nerve actually comes from the phrenic nuclei between C3 to C5. These patients also tend to lose their ability to what? To swallow, because we know this is where the medial nuclei, the medial group muscles of the medial muscles of the trunk and also the neck. So hence this patient will be unable to what? Breathe and what? Speak. So this patient tends to even die within 5 years. The cause of this disease is actually what? Unknown. We'll talk about polymyelitis, which is actually which is actually a viral infection that one can get due to a virus which actually enters the body via feces. What might bathing in and that's why it's even important to vaccinate children against this disease, as you find that it also affects the anterior horn motor neurons. As you can see, this patient tends to die from paralysis of the respiratory muscles. We know this is where the phrenic nuclei is located. So when it's affected, meaning the diaphragm will be paralyzed and the patient won't be able to respirate. Yeah, so this is there's what we call the subacute combined degeneration of the cord. So the subacute combined degeneration of the cord is actually just a condition that is actually due to vitamin B12 disease. Vitamin B12 deficiency, sorry. And we know vitamin B12 actually plays a major role in the myelination of nerve fibers. Yeah, and these are patients, it's also associated, and these subacute degeneration of the cord is actually even associated with what? Pernicious anemia. So that's why it's important to, when you find a patient who is an alcoholic and patient that you find that they're presenting with loss of tactile discrimination, loss of vibrational sense, impaired proprioception, and maybe they are alcoholics, and you find that they are deficient in vitamin B12, they are deficient of vitamin B12 deficient, they are vitamin B12 deficient. And remember the time I was rotating as a final year student, most of the patients that were presenting with pellagra were presenting with subacute combined degeneration of the cord. Yeah, it's actually a common condition, especially in those that malnourished and those that take a lot of alcohol, because they tend to eat enough food. Yeah, tend to have regular meals. Yeah. So syringomalia is just actually accumulation of fluid, in the spinal cord. So this mostly tends to affect the cervical segments. This tends to affect mostly the cervical segment, and tends to lead to the destruction of the central canal and the surrounding areas. So in the case that maybe this lesion, this cavity has been formed in the anterior white commission. So this is why you're going to find the patient might present with bilateral loss of pain or temperature sensations below the lesion, because we know this is where the spinolateral spinothalamic tracts tend to cross over, and we know the lateral spinothalamic tracts are involved in pain and temperature sensations. But you find that due to that, it's the lateral spinothalamic tracts that cross over the anterior white commission. So you find that other sensations below the lesions are actually intact. They're actually preserved in the uncrossed tracts of the posterior columns. And this is what I think is, so people that have intractable pain can actually be treated with two procedures. where in rhizectomy, I've actually resected. Why? The spinothalamic tracts on the side, on the opposite side of the pain. Like I said, seeing they're crossing over so many. Where you're having pain on the opposite side, you have to resect those spinothalamic tracts. These tabes, we'll talk about the tabes Basalis, which is actually a syphilitic degenerative lesion of the posterior right column and the posterior nerves, which actually tends to, we know that in the the posterior aspect, like the diagram, the posterior aspect of the spinal cord is actually involved this is what the Basalis and these are information, sensory information for proprioception, vibration, fine touch, and if there is degeneration of the nerve cells of the neurons in this area, so meaning there'll be ends leading to what they call Rhombex. Without them being able to, they'll be unable to tell their position minus them opening their eyes. Yeah. So they have to look for them to tell that, okay, this is where I'm standing, this is where this is. But if you told them to, in a case that maybe you told 6% to stand while they're having their eyes closed, they might even stagger and fall. And that's what we call the Rhombex sign. Yeah. Thank you very much for attending. I know it was quite a long lecture. Yeah, to be covered in one segment. Yeah. I hope people and some of them are bled.
Thank you so much. Thank you so much, Dr. Paul Mutambo. Thank you so much.
Hello, is everyone?
Yes, we can get you. We can get you. We're here. Just want to appreciate you for your time. Appreciate you for this wonderful presentation. So, and also, Dr. Noru, wonderful seeing you here. And Lolen, I don't know if there's something that you want to say, please.
Thank you very much for this brilliant anatomy presentation, neuroanatomy presentation about spinal cord. I really love so much this part of the body. It might be a little bit long, maybe that's why we lost a lot of the audience, but it is okay. It's not easy to talk about spinal cord anatomy in the short times. I recognize that. I just want to congratulate you for your well done, Dr. Mutambo. And I think you quite how can I say that reach out the correlation between the neuroanatomy and the clinical, and I appreciate that a lot. So congratulations. And I don't have any question, just to congratulate you, but it's a little bit long. Maybe next time, maybe do that in the 2 or 3 parts or 2 parts might be more attractive because it was a little bit so long. However, congratulations.
Thank you so much. Thank you very much, Doc. I really appreciate it.